Okay, welcome everyone. Just housekeeping, to say that this meeting will be recorded and the recording will be made available afterwards. And if you can leave your microphones and cameras off, unless you're speaking. Thanks. Okay, so good afternoon and thanks for joining us for the launch of the Reimagining the Relationship Between Universities and the NHS report. We hope this event will provide an opportunity to discuss the report's findings and explore the role of universities and NHS organisations working together and contributing to their local place. I'll be hosting the session today and I'll be introducing our panel in a moment, but just a few words from me to set the context. For us as a university, this work and how we make a positive impact on society is hugely important. Newcastle University can trace its roots to the School of Medicine and Surgery, which was founded in 1834. And we led the way into research into public health issues that affected the local population at that time. Today, we help train the workforce that the NHS needs, and our world-leading research finds solutions to some of the world's biggest health challenges. But we recognise that there's much more we can do. Despite the work of many outstanding organisations, including our local NHS trusts, the health outcome of our local population remains poor, and health inequalities remain a huge issue. The pandemic has highlighted and exacerbated many of these challenges. A recent Northern Health Science Alliance report, The Unequal Pandemic, co-authored by my colleague Professor Claire Bamborough, found that people living in the North had a 17% higher mortality rate due to COVID-19 than those in the rest of England. Around half of the increased COVID-19 mortality and 2/3 of the increased all-cause mortality in the North were explained by preventable higher deprivation and worse pre-pandemic health. This has a direct impact on our economy, and the report estimated that these inequalities could cost the national economy up to £7.3 billion in lost productivity. There's been a growing understanding both nationally and locally that to address these challenges, we have to work together and take a place-based approach. The NHS long-term plan confirmed that all parts of England would be served by an integrated care system from April 2021, building place-based partnerships to coordinate services and to plan in a way that improves population health and reduces inequalities between different groups. Similarly, the Civic Universities Commission focused on the role of universities in place and how we maximise our contribution. Here in Newcastle, we have been working together through Collaborative Newcastle, which brings together partners in the NHS, local government and universities to support the health, wealth and well-being of the communities we serve and to share learning nationally and globally. The report we are launching today, Reimagining the Relationship Between Universities and the NHS, has been developed by the Civic University Network, of which I'm proud to say Newcastle is a founding partner, and the NHS Confederation, bringing together experiences and examples of best practice from across the country. I'm delighted to be joined by colleagues who have played a key role in its development and who will talk about the report and how we can build on our partnerships going forward. Dame Jackie Daniel, CEO of Newcastle upon Tyne Hospital's NHS Foundations Trust. A good friend and colleague, Jackie has a long and distinguished career in the NHS, as well as having many national roles. She's been a leading force in the development of Collaborative Newcastle. Jackie has chaired this initiative alongside Professor Steve West. Steve has been Vice-Chancellor at the University of West of England, Bristol since 2008. Having originally trained as a podiatrist and paediatric surgeon, Steve is currently President of Universities UK. I'm also delighted to be joined by Matthew Taylor, who joined the NHS Federation as its new Chief Exec in June 2021. Previously, Matthew led the Royal Society of Art for 15 years and was Chief Advisor on Political Strategy to Prime Minister Tony Blair. After we've heard from our panel, there will be an opportunity to ask questions using the chat function. I'll then hand over to Michael Wood from the NHS Confederation and Jane Robinson from Newcastle University, who developed the report to talk about the next steps. Jackie, if I can pass over to you to give a short presentation on the process behind developing the report, including key statistics and insight from roundtable members. Thanks, Jackie.
Thank you, Chris. And before we share the slides, just welcome to everybody. Thanks for joining the session. You know, this report really brings together a culmination of a whole year's worth of work, and I've been really privileged to be able to be involved in it and share some of those key key sessions. We're going to share a little bit, unpack the report a little bit for you. But as Chris has said, I think I've been in healthcare now over 40 years. I've been a chief exec for the last 20 years or so. And there was a time when, as a healthcare chief exec, especially in acute care, your job was to run the hospital really, really well. And let me be clear, that is still the case. It's still my job to run the hospitals really, really well. But it's really occurred to me over the last number of years in particular that we've got so much more reach, particularly as large anchor organisations in healthcare. And that we can actually also take responsibility with partners for general health, wealth, and the economic development and well-being of the population. So take on a much, much broader role. And I think that's really, really important, because in Newcastle, it's a complete privilege to lead an organisation like Newcastle Hospitals. Many of you probably know it's been rated outstanding twice by the CQC. It's got an incredibly reputation, not really because of anything I do, but because of the wonderful work that 18,000 staff do across our organisations and out into the community. So, you know, thinking about how we use the £450 million procurement budget that we have every year to put, you know, bend the curve and actually, you know, do business with local businesses, as it were, to drive up that local economy, to drive up jobs in the region and make a difference to people's lives. And that's what really turned the dial on some of the deep inequalities that we still have in this part of the world. So despite the fact that we're outstanding, you know, we've got inequalities of depth and breadth. And frankly, after 2 years of the pandemic, they're even graver than they were before it. So I think the relationship with universities and the NHS is really special. It's been ever present during my career, but it is one of the oldest and strongest partnerships, and we should really cherish it. But I think as we emerge from the pandemic and we look at what we now need to do to recover in every aspect, and in particular rebalance the economy, there's a lot that we can do in reimagining the relationship and really thinking afresh and anew about what we can do together going forward. And I think it's interesting that I spend a lot of time at the moment talking about integrated care systems and, you know, the new world as we'll emerge into next year. And I'm disappointed at how little the university higher education sector, how you know, little it's mentioned. And I think we need to remedy that really. So if we could have the first slide, please, Shireen. So working across the partners of the Civic University Network and the NHS Confederation, we really set out to do three things in this work. We really wanted to make a difference locally in what we call kind of places. We wanted to be able to co-produce a set of principles about how universities and how the NHS could work together to maximise their collective benefit to the society and the broader economy. Secondly, we really wanted to, and particularly now, it's so important as we work into this world of system working, that we wanted to be able to influence national policy frameworks around not just integrated care systems, but you know, the research and innovation roadmap, to make sure that the inextricably linked roles of the NHS and universities were recognised. And then thirdly, we wanted to explore just how we could contribute to the future of the nation now, particularly around the agenda of levelling up, particularly in the context of the inequalities that have been driven deeper by this pandemic. Could I have the next slide, please, Shireen? I want to try and ground this session in some sort of real life. So I'm going to tell a story that's one of Newcastle, just to give you some examples of what we've done. Chris mentioned our partnerships that we're very, very proud of and the work that we're doing, but let me just bring it to life a little bit more for you. I often talk about as a leader in a large NHS organisation, that part of my job is to create real sticky edges around the organisation to make it as easy as possible for others to collaborate with us. Whether that's, people in GPs in primary care, whether it's the voluntary sector, the university sector, the commercial sector. And I don't think we've been particularly good at that in years gone by, and we definitely now need to get much, much better. So a number of years ago, we created this brand called Collaborative Newcastle, and it's really the shared approach that we've developed between key partners in the city region, and the way that we work together on improving health, wealth, and well-being. And I hope you can see by that slide, there's a really broad range of partners involved in this, and it's growing actually by each kind of month, literally, as we move through. But a couple of examples, if I might. So what we've done really successfully, I think, is created an integrated health and care delivery system. Now, that's happening in a lot of places across the UK at the moment, where partners are able to literally transform the way that care is delivered. It's a really ambitious programme we've got in Newcastle. We've pulled budgets, we've got really good data and analytics that are driving population health management. We've created one team between social care, community services, mental health, and the voluntary sector, wrapped around primary care networks in the city. And it was really great to win the HSJ award for partnership working just last week or the week before. So that was great recognition. So that's one example. The second example that you'll see if you come to Newcastle is we effectively sold the old general site in Newcastle. It was a kind of defunct healthcare site. And we are redeveloping that with our university, city council members, and with others into a campus for ageing and vitality. We've got a really big shared ambition to create the world's premier centre for healthy ageing, and also people that are ageing and living on the site. It's owned by the university, but I think we are developing the vision and regenerating what is a very poor part of the city to make sure that in the future it's a go-to place, not just for innovation, but for evaluation and demonstrations of new technology and new lifestyle approaches for older people. So we're very, very excited about that. Bringing right up to date with the news of this new variant, what we did during the pandemic was built an integrated COVID hub for the North East. It's one of the largest lighthouse laboratories in the UK. We're processing, it's got a capability of about 40,000 tests a day. But what we did was not just create a lab, which is great, but we also created a coordination and response centre, providing COVID and population health analytics, driven from testing and other data. Now, that bit of our lab is based in the university building, and it draws on expertise of the university's National Innovation Centre for Data, which again is something we have here in Newcastle. And we work really closely with our council public health teams. But we couldn't have done that without the help and support of our universities. We also created the third leg of the integrated COVID hub, which is our innovation lab. And again, that's in housing university buildings. But what we're doing there is working with Jenny Harris and the UK Security Agency in developing the latest testing approaches for COVID. We're using the university's genomics expertise to develop and evaluate the effectiveness of point of care testing. And that's so important. And I think it'll be a lasting legacy, really, of the work that we've done together. So I hope that gives you some examples of the added value, as it were. Jane, if you can have the next slide, please. But let me tell you a little bit about the journey we've been on. We've been working to develop this report really over a year. Initially, we hosted an initial webinar that was back in November 2020, and we had about 150 participants across the NHS and across higher education. And we use the key discussion topics from the webinar. It's a really rich discussion to facilitate then 3 more focus roundtables with leaders across the NHS, higher education. We also have people from primary care, from local government, from the third sector and further education. And what we did there was we tested and socialised some of the conclusions, and we tested them further at lots of subsequent events, and also at the NHS Confederation Conference and the Civic University Network Conference this year. So, you know, it'll be interesting to see, maybe following the publication of this report, I really hope that you might choose to host your own regional roundtables to sort of test further those guiding principles. And maybe, you know, I would hope that we're still talking about this at next year's Civic University Conference. And obviously we'll pick up, and Michael and Jane will say a little bit more about that towards the end of today's event. For the next slide then, through those conversations, as I say, the conversation was really, really rich. Those that participated, they shared their views about what was working really well now, what ambition we could set, what needed to change if we were to truly realise the potential of this really special relationship. And there were several themes that kept coming up time and time again. I mean, an obvious one is the fact that we do need that collaboration and that co-development. How are we clear about how we use each one another's skill in our day-to-day work? Play to our strengths. You know, there's so much that we can do together. How do we talk together or operate together when we're talking to audiences outside of our places? Another theme was, how do we take on that shared role in building the future? Whether we're talking about the all-important at the moment workforce, or how we use and make best use of technology going forward. Another big theme, not surprisingly, was one I've mentioned, which was how we tackle inequalities and maximise our impact, because you know, we've got now fantastic evidence and research. We don't need any more of that. We know what we can do to deliver improvements for our populations, but we're going to make so much more pace if we work together and we don't keep reinventing the wheel all the time. So on the next slide, we just show here some of those guiding principles that came through time and time again on the conversations that we had. Obviously, there's more detail in the report which you can unpack, and there's some really great, I think, some hopefully very helpful signposts to good practice of work done by people up and down the country. And I hope that will really inspire people to see how the principles can be put into practice. Next slide, please. I hope again that you'll find helpful the questions that might, you know, sit at the centre of focus group discussions, might help you think about how you start to test some of these principles in your own local university NHS partnerships. I think they're really useful tests and good prompts for our future work. You know, when I've been involved more recently about the design of our integrated care system, it's been really important to me to be asking where our universities are going and what part they will play in the new way of working for the NHS. So I guess just to conclude from me at this stage, just a thanks for the whole team that have been working on this. It has been really inspirational, really inspiring for me over the last year, and I'm grateful to be part of it. Chris, perhaps at that stage, I'll hand back to you, and really look forward to further discussion that we'll have this afternoon. Thank you.
Thanks, Jackie, for that really excellent scene-setting piece. I've been told that we don't have Steve West. Ironically, he's stuck in an NHS board meeting, so he's putting the report into practice. I do have Peter O'Brien, who's the Exec Director of Yorkshire Universities, who will come in a minute and give a perhaps a different university perspective than perhaps hearing from me as a substitute, because you'll probably think you've heard too much from Newcastle. So I'll come to Peter in a moment, Peter, just to warn you. Perhaps first I'll go to Matthew Taylor, who I mentioned before, is from the NHS Confederation Chief Exec, to give perhaps the NHS view of the report. Matthew.
Yeah, thanks very much, Chris, and it's great to be here. I've been at the Confederation for 6 months, and it's been a process of kind of moving up a learning curve, but also understanding more about the organisation. And one of the things that's been a real delight for me on that journey has been to get to know the work that Michael's been doing, because I think that's incredibly important work. And had this work not been started, I think I would have been arguing that it should start, because it reflects a long-term interest that I've had. My enthusiasm, the concept of the Civic University, goes back many, many years to many conversations with John Goddard, 15 years ago, when he was really, such an innovator in this space, and I've even intervened in certain ways. I was on a commission that Warwick University set up on its kind of role in the local and regional economy, which I think it partly set up in recognition of the fact that Coventry University was doing so much more and was so much prouder of its kind of local relationships. So yeah, I'm delighted that we're doing this work, and it has absolutely my full backing. And indeed, one of the things that I'm introducing in the Confederation is that we've not had, or we've certainly not had for some time, a set of kind of impact objectives. That is to say, what is it that we as a Confederation are trying to achieve beyond advocacy on behalf of our members? And that's involved us thinking through some of the shifts which we think are necessary if the health service is to thrive in the medium term. And one of those goals is going to be around understanding and enhancing the role of health in the productive economy. And we might phrase it slightly differently than that, but for me, that's an essential goal for us for all sorts of reasons, actually. So, as I say, this work, very important to me. And I think, to be honest, that it's not amongst the top priorities of a lot of health service leaders. And my commitment is to do everything that I can, working with great leaders like Jackie, to change that. And in the context of system working, to get to the position where really most health leaders, or certainly most health leaders at a system level, see this kind of wider role for health in the local economy, those wider relationships, understand that. And of course, the university relationship is a really important part of that. So, I endorse everything in the report. I think it's great work, and I'm looking forward to where we go next to this. I guess, rather cheekily, I thought I'd kind of make 3 points that I would have made had I kind of been involved in developing the report, which are not to take away from it anyway, but just kind of reflections on conversations that I've had before around kind of challenges of working with universities. So the first is, I don't think we should ever underemphasize the importance of simply institutions and institutional leaders understanding each other. I remember when I was doing work on local government higher education relationships, that one of the things that was often a challenge culturally was that vice chancellors aren't really in charge of universities in the same way as chief executives are in charge of local authorities. Or I suspect the way in which chief executives are in charge of health service trusts and foundations. Now, the way in which health service leaders will be in charge of systems may be more similar, but it was quite an important kind of cultural step in local government university relationships for the leaders to understand the kind of constraints each other were under, to be in each other's shoes. And I just think it's really important not to underestimate that. And that's one of the reasons why we need a very local approach to this, and why, obviously we talk about relationships being important. if you thrust institutions together when they don't really understand each other, they don't really understand the leadership challenges, it's not likely to work. So this is implicit in the report, but I just think leaders getting to understand each other, spending time shadowing each other is an incredibly important part of making this relationship work, actually. The second of my 3 points would be that, and I kind of hesitate before saying this, because any of us in the health service are sick to death of being told to count things and report on things. And sometimes it's useful, but I'm afraid too often it isn't terribly useful. And it's about kind of box ticking from the center rather than anything particularly useful. So I hesitate, but I still want to make this point. I think we need to find a way as we move forward of auditing the relationship or measuring or describing the relationship between universities and their local health systems. So what are the kind of criteria by which we can have a sense of how strong those relationships are? There are so many different dimensions to them, but it would be good to start to think about a kind of typology for describing those relationships so that people know where they are on a journey moving towards stronger and stronger relationships, better and better synergy. And part of the reason I make this point is because something rather interesting that happened when I was a member of the government's Industrial Strategy Council, which of course was chaired by Andy Haldane, who's now leading on Levelling Up white paper, or at least he's leading at least one of the teams on the Levelling Up white paper. We did a piece of work through the Industrial Strategy Council. It was actually quite controversial, which was we did commissioned some work really pounding through the data. And we looked at the relationship between universities and innovation and enterprise, the relationship between universities and kind of spin-offs in terms of value added in business. And the really important thing about that study was it did not reveal what you would have thought it might have revealed. That is to say, there were some universities, unheralded universities, that had an incredibly good record, actually, at floating out its innovation, developing really strong business links, being able to demonstrate really concrete ways of forms of knowledge transfer. And there were other universities who are very good at publicizing themselves, who it turned out actually weren't nearly so good at doing it. So I think there's something interesting about how do we kind of provide a basis for understanding the relationship between universities and health service, which enables us to get behind kind of rhetoric and look at the specific dimensions of it and start to explore how it is we might give places, hold a mirror up to places in terms of them understanding where they're progressing, where they're not progressing, where they could progress further. And then my final point, which really just reinforces a lot of what Jackie said, but I do think it's important, which is that there can sometimes be, can't there, whenever we talk about collaboration, completely understandably, a tendency to sound as though we're promoting collaboration for the sake of collaboration. And of course, in the end, it's collaboration for a purpose, and that's what the report said, and that's what Jackie said. So I guess, you know, in this conversation, the more that we're able to surface problems, specific problems, identified local problems where the relationship between universities and health system has enabled progress to be made in solving that problem, the better. And I just think we have to continuously return to the fact that the proof of the pudding lies in problem solving. I mean, I feel the same, by the way, about the concept of integration, which we're always talking about in terms of health and care, and the debate about the integration, white paper. What is integration ultimately for? For me, it's ultimately probably about two things: improving care pathways and improving population health. But I think similarly, when we talk about health and higher education, the more that we can return to what are the kinds of problems we're trying to solve, and the more that we can share and champion those concrete accounts of this partnership solving problems that matter to people, the better it will be. So look, really exciting. This is the beginning of something which I think will grow and grow, and which the Confederation is deeply committed to.
Thanks, Matthew. Really, really interesting 3 points there, which I'm sure we'll come back to in the questions. Peter, do you want to give your Yorkshire University's perspective on this report? Thanks. Thanks for stepping in. Thanks.
No problem, Chris. Yeah, hope you can hear me okay. So just a little bit, very briefly, Yorkshire Universities, we're a membership body of 12 HEIs and universities in Yorkshire and the Humber. And I'm the executive director. So we've had I think, a very fruitful relationship with the NHS Confederation as a group of universities. I'm delighted to see this report with the Civic University Network. So hopefully what I say here, I think will have some resonance for other regions and not just Yorkshire and the Humber. So I think there's three areas I'll probably pick up where universities and the health and care sector are working very closely together in Yorkshire. One's around research and innovation. So clearly world-leading research that our universities do and have been doing, not least in response to the pandemic. Thinking about those health inequalities has been absolutely central to our universities. I could think about the Born in Bradford initiative. You've got Kate Pickett's work in York on health inequalities. And really how universities in the NHS really pulled together during the pandemic, not least thinking about our medical students, accelerating graduation, equipment, kit, space, etc. And it's ongoing. So I think that's really deepened that relationship. Secondly, and I think this is a point that's made in the report around skills and training and planning for that workforce of the future. And I think that's absolutely critical. Where's that supply and where is that demand going to come from? And one of the things that we've been doing at Yorkshire Universities is, and I guess it's responding to a demand from the ICSs, is to make sure we're much more collaborative as a higher education sector. That's not always easy because a lot of the system, if you like, encourages competition. But to think about where the future workforce is going to come within Yorkshire and the Humber and how we can plan for that in a much more systematic way. So the Workforce Observatory pilot that we're running with Health Education England and the University of Bradford is a really important part of that work, alongside FE as well. It's not just universities, the FE sector has got a critical role to play in all of that. And I mentioned health inequalities, and I think those, as I think Jackie alluded to, have unfortunately exacerbated since the pandemic. And I think we need to think about how we can tackle that. And one of the things that we are doing in that area, which is worth perhaps just highlighting, is to see what more we could do through our universities in terms of being providers to try and embed more around health inequalities, equality and diversity in our education courses for our medical students. So that's another piece of work that's ongoing within Yorkshire. And finally, I think the third point, Chris, is around that wider civic role, that social role. And that's pretty important in a number of different areas, not least in terms of coming together with the health and care sector to ensure that health is embedded within economic recovery plans. It might seem an obvious point, but I think it's not always necessarily has been the case. And our work with the NHS Confederation, with Michael, with the Academic Health Science Network on our Why Health for Growth initiative, has certainly enabled us to make the case for health to be embedded within mayoral combined authority plans and strategies, and also at a local level. And finally, I think from a university perspective, our students clearly are incredibly important and have had a tough time over the last 18 or 20 months. And one piece of work that we are doing with all the universities in Yorkshire and the ICSs and OHID and ONS is we have a network which is looking at student mental health, where we share what's going on within our institutions. We make sure that we're learning from each other, and we're working with our student unions, because clearly this is an important piece of work, and we want to make sure that our students as graduates are supported as they enter the workforce. So delighted to see the report, Chris, and happy to step in. Thanks very much.
Thanks, Peter. So now is the point to invite questions if anybody on the call would like to ask any. So if you put them in the chat or stick your hand up. While you're thinking, I'll just give you my reflections as one of the, I think there's 4 medical vice chancellors in the Russell Group. So I have a little bit of a different perspective to perhaps a historian vice chancellor. I absolutely agree with Matthew's point about the personal relationships. I think if they don't work, I think then all of this is very difficult to get cascaded down through the organisation. And the relationships that Jackie and I have, the relationship with the City Council Chief Exec, the other Vice Chancellor in Newcastle, I think they are vital, that they are as close as possible for all the reasons you described. We all have different targets, we all have different masters we're serving, and we have to understand those perspectives. It obviously helps from my point of view that I spent 9 years on the Hospital Trust Board as a pro Vice Chancellor, and that may be why it's as close as it is in Newcastle. I think the other thing I would reflect, I suppose, for years medical schools will say, of course we work with hospital trusts. We produce medical students or in our allied professions in the case of Northumbria, and they go out into the health service, and we do research on patients who are in the trust. And I think no one would argue that's been going on since time began. I suppose where I'm seeing this difference is seeing us as such major employers of our places, working with the city council and saying, what, other than the normal stuff that medical schools and hospitals do together, which is to train students and presumably do and adopt research, it's those sort of anchor institution employers, purchasers, worrying about local issues rather than just doing stuff in isolation. I think that's the third piece, isn't it? That's what this is all about, really. What's the added value? And I think, Matthew, my answer to your question about how do you measure this, and there have been attempts to do it, obviously. I mean, academic health science centre status, for example, which is designated by NIHR, is given to those medical schools and trusts that can demonstrate the added value of working together for patient care. But I suppose it would be, what could you measure? I think what you would measure might be difficult, but what you could do, is gather a number of sort of almost, to use university speak, sort of impact case studies of things, as Jackie gave some of those on in the talk. These are things that we have achieved together, whether it's us two with the city council ever, that we would either not have achieved at all or would have achieved much slower if we'd worked in our own little silos. And I think, gathering across the country some case histories like that of this is what we've done that we absolutely wouldn't have done or done slower would be really useful, I think, for those partners who are perhaps at different stages to say, look, that's what you can do if you get this right. That would just be my go at how you might start to think about that. I've got a question from John Goddard, Michael, Matthew, who you mentioned in your introduction there.
I wouldn't have been nearly so nice about him if I knew he was here.
Here in the call, absolutely. Please elaborate on changes needed in training medical students to embrace issues in the report. It's an interesting question, John. I can have a go at that. I mean, Peter might want to reflect. I think it's back to what I said, isn't it? That the very classical way of teaching a medical student about, these are the organs in the body and this is what you need to know about it. This is how you treat illness. To introducing into medical student curricula issues around things like health equality, much more around preventative medicine, the advantages of working in different healthcare systems, etc. So I think I would say, wouldn't I? Some of those aspects have made it into the curriculum in Newcastle, competing with the usual stuff that they have to learn. But I think they're going out to be responsible citizens, John, and it's in their places, and it's our responsibility to have some of this in their curriculum. But one could argue, you could say the same thing for most university curricula. Actually, there should be a lot more of this place-based stuff in all of our curricula, to be honest. Any other comments from my fellow panelists, having heard what the others have said? I don't know, Jackie, whether you had any reflections or.
Yeah, I did. Yeah. I mean, I'm thinking about the work that we're doing on shared leadership across Collaborative Newcastle, Chris. We've got that programme running. It's been running now for 2 years, but there's something, John, about further integrating learning and learning together. So I would imagine, it's not just medical students, but, consultants and other sort of clinical professionals. But I think it just builds on Matthew's point about we don't know what we don't know about other worlds. And it's been absolutely inspirational to hear the learning about what we can do very effortlessly, actually, in transforming care. When social workers are put in a room with clinicians, physios, and and mental health professionals, it's just a game changer. So I think there are so many layers to this, and I think if we can bring what we bring as institutions in our own right, but then overlay that on what's happening dynamically in place, it's really, really exciting, really interesting.
One thought I would just, kind of slightly random thought I drop into this conversation is that we have this massive workforce crisis in health and social care right now. And one thing that we could maybe do a bit more is to for universities to work with health and care systems to tell people about to graduate about the careers they can have in health and care. I remember, Jackie, a piece of work that was done many, many years ago. David Miliband used to talk about it. It was done by the CBI in the North. And they asked working class boys in the Northeast what jobs existed in the health service. And those boys said there were 3 types of jobs: doctors, and they weren't bright enough to be doctors; nurses, and that was girls' work; and porters, and they didn't get paid anything. And that was it, right? So the point was, they had no idea that there was such a wide array of different kind of jobs that you could get into and the different points at which you get into them. So I take that one point. And then another thing I wanted to share, because it was such a joy, is reading Madeline Bunting's book, Labours of Love. There's a lovely story she tells in that about a bloke who's a roofer. And his family say he's a bit of a miserable git, basically, and he can't be a roofer anymore because he's done his back in. And then somebody, for some reason, he just decides to become a care assistant. I don't know why, he just thinks he'll do it. He falls in love with it. And not only does he dedicate his life to it, but his family said it completely changed him. He began to be a kind of garrulous, warm, empathic person suddenly. Anyway, the reason I say all of that is that, you know, there are a lot of people who may have done all sorts of different degrees, and they've done that degree because they love that subject, but they didn't necessarily a job in that subject. They necessarily want to become an academic or whatever. And actually, if they understood the range of jobs that exist in health and care and the way we can get into those jobs, regardless of what degree you've done, you can, you know, there's all sorts of really interesting fast track ways, for example, to get into caring roles. Anyway, that might be something. So let's just not think about the people who are in universities because they're training for medical careers. Let's think about all the other students who might be thinking, what am I going to do next? And actually, there is a job where you are needed straight away. And actually, there is a career path for you if you like it.
Yeah. Thanks, Matthew. So we have a question there from Helen Featherstone about whether the panel can elaborate more on the role of health and economic recovery. It makes sense, but I'd love to hear a bit more detail. So I'll just comment on, there was a report done by, again, Northern Health Science Alliance a couple of years ago. I think everyone accepted the evidence that if you live in an area of poor economy, that reflects on health, things like obesity, smoking, etc. And we've always thought that perhaps the other way around also made sense, but that report quantified it very clearly and showed that if you could bring the average health of people in the Northeast up to that of the country, the difference it would make on GDP of the Northeast was actually enormous. So the data is very clearly there. So that, you know, the very simple answer to that question, Heather, is that if you make the population healthier, the economy will benefit for fairly obvious reasons. People will be in work, they won't be making sick pay, they'll be part of that productive community. But I don't know whether others wanted to come in on that. I think Hamish Lang, you want to give us the Welsh experience, I think, on the role of health in the growth deal. Is that right, Hamish?
Yes, I'd be delighted to. Good afternoon, Hamish Lang from Swansea University, but I'm also I'm a doctor. I was a medical director in our local health board, and as you know, we have university health boards in Wales. So there are the health boards are aligned to universities, and we work very closely in Swansea University with the 2 health boards that serve South West Wales. So they employ something around 25,000 staff, and they spend getting on for 3 billion pounds a year. So that they are a big anchor institution, and we have a formal partnership between the university and those 2 health boards, a formal collaboration called ARCH, a regional centre, a regional collaboration for health, and we work very closely when there was an opportunity for a growth deal, a city region deal, to make sure that, in fact, about a third of that deal was about the health and well-being of the population of South West Wales. And that's bringing £1.3 billion worth of investment into the region, specifically to improve the economic opportunities for our communities. We have a GVA of about 70% of where it should be, so a real opportunity to drive up high-skilled jobs, and improve the health of our community through improving their wealth. So a very specific example of this. There is a lot more we could do together in the foundational economy, but we've made a start, I think.
Thanks, Hamish. Jackie, did you want to come in on this point?
I guess just a couple more examples. I mean, they're really, really good examples, Hamish. And similarly, we've been focusing with our local enterprise partnerships and our, you know, business partners, on what we call the growth and prosperity arm of Collaborative Newcastle. Sounds like we're doing some similar things, but really practically, you know, when we built the lab, we targeted the most deprived areas of our community because we had the opportunity to create 900 jobs overnight. And that made that, you know, that's got the potential. We're also doing some really interesting longitudinal research, again with our university partners, about the impact that that might have on life chances across, you know, across the course of what we hope will be long-standing careers in health and care. So I think it's littered. I think, you know, we're only held back by the scope of our imagination. And I think it's really creating permission to you know, to go into new territory together, to just pool ideas, because as you, I mean, Hamish, you were talking about the size of these organisations. We're probably similar size in the Newcastle region, you know, massive employers with massive procurement budgets that can really, really make a difference if we focus together locally. Thanks,
Jackie. Okay, so I don't think there's any more questions in the chat. So I'll now hand over to Michael Wood and Jane Robinson, who are going to discuss how audience members might want to use the recommendations in the report and share progress on the Civic University Network. I don't know, Michael or Jane, who's going first.
Thanks, Chris. I think I'm going to kick off and then hand over to Michael. I think the first thing to say is thank you very much for all to our speakers and to those who've contributed today. I should say that Michael and myself have also worked very closely alongside Emily Burns from Queen Mary Hospital and the team at Sheffield Hallam, who support the Civic University Network. So it has genuinely been a hugely collaborative exercise. And many people have been involved, as Jackie was saying, in roundtables and discussions to get us to the point we are today, but was very heartened to hear Matthew's comments that had this not started, he would be looking for us to do something similar, because I know in conversations with colleagues, we do see this very much as the beginning of a journey and a set of contributions and conversations that feel very timely in terms of both the national policy agenda, but also some of the key issues that we are facing in different places around the country. So I'm going to hand over to Michael, who's going to talk about some of the things that we're thinking about in terms of next steps. But before I do, can I particularly thank Dame Jackie Daniel, who's been a fantastic supporter and advocate and has given a huge amount of time to helping us in taking this work forward, and also to thank Peter O'Brien for sort of stepping into the breach so admirably at the last moment. So thank you very much to our panelists and to everybody who's contributed thus far. I'll hand over to Michael to close the session and say a word about next steps.
Thank you, Jane. And yeah, absolutely. Let's start by echoing that thanks to today's speakers, to the people who've contributed throughout the process, the roundtables or the conferences, and to the team at the Civic University Network. Absolute pleasure to work with. And we wanted to finish with, I guess, a bit of a call for action. And I think just going back to when Jackie was starting, and it took me back, I think it's almost 8 months to the day, Jackie, the first roundtable. So my mind is whirring back then. And there was something about the partners around the table were coming together at a particular time where this relationship was incredibly strong. It was incredibly visible. It was as the vaccine rollout was really progressing. It was at the forefront of the excellence and the recovery. And yet everyone around the table was thinking, actually not reflecting on how we can further develop this path towards excellence. Everyone around those roundtables, those virtual tables, was actually thinking, what more could we do? It felt like a moment just to take stock on actually how well we've worked, but yet looking at what we knew and what was evident in our own communities, which was absolutely those inequalities widening. And I was really taken back then about the openness and the intent to really get under the bonnet of each other. And Matthew's comments about that first point about, do we really know each other? I think, and do we really spend time in each other's in safe spaces, understanding what success looked and felt like, I thought was so important. So that, I think that spirit has blown through this work. And now what we're interested, we think this report is not the end of a piece of work, it's the beginning of actually what needs to happen. And I think normally organisations like my own, Matthew will know this, we produce reports, we face national government, we come up with a list of recommendations and we click our fingers and make demands of government. What we've done this time actually is we've held a report up to ourselves, and this report is for the Dame Jackies and the Steves and the Peters and the Chris's, you know, in the local leaders to say, well, actually, are we doing enough? Do we really understand what we need to do as a duo, as a relationship? And then how can we then face outwards into our local community with that one voice? And so we're really interested to see how people want to use the report going forward. I'm sure there'll be a sliding scale of on the coffee tables of some private discussions right through to actually using it to really reinvent and reimagine what we do. And I'll just use a conversation recently with colleagues across the NHS University down in Plymouth rather, just to show the sheer breadth of the country from Newcastle right down to Plymouth. And the university and the NHS in Plymouth are thinking how they can get health in those city strategies, which have been largely economic in the past. And actually, they're trying to now think how we can use this report to bring together the leaders across academia, across the NHS, to really understand how they can work together before then going to their external partners across the city and reimagining that citywide conversation. So I think a great example there of actually how people can use this report and this issue to bring together. And I think what we'll finish with on behalf of Jane, I and Emily and colleagues is an offer, I guess. How do you want to use this report to reimagine your local relationships? How can we support you on this? Is it that we come and we help support you with roundtables, we co-host events, we bring partners together? Matthew's spoken and Dame Jackie have spoken about the challenges facing NHS leaders. Can we bring some NHS colleagues, reach out to primary social care, get them in a room with the breadth of HE and FE and local colleagues to kickstart some local conversations? So if the Confed and the CUN can help you, please do come to us. And I think our very final ask is to keep in touch and to send your local examples in. We will be profiling local examples on the website. This is a continuous journey. It's not a one-stop shop. Let us know what works. Let us know what doesn't work. We will feed that into our conversations. We will promote your local work and excellence, and we will keep supporting. And that's a commitment I can make on behalf of the Confed in Matthew's presence, which helps, and which our CUN colleagues can make as well. So thank you for coming. Thank you for all the work. Dame Jackie, thank you for chairing us throughout these 8 months.
Great, thanks very much, Michael. So my personal thanks to you and Jane for putting this afternoon together, as well as all the other thanks for those involved in producing the report, including some of my other panel members. Thanks to you as an audience for your input and comments, and let's hope that you rise to the challenges that Michael has set you of using this report to improve the integration of the university and hospital work in your own areas. And we'd be very pleased to hear about it as you go forward, perhaps using the Civic University Network as a sounding board. So thanks everyone again for attending. Really enjoyable event. Thank you, everyone.